Good afternoon. My name is Dr. Sean Lin, and I'm a clinical assistant professor of cataract and refractive surgery at the Jules Stein Eye Institute at UCLA. My job this afternoon is to present to you cataract surgery updates in the year 2022. And my secondary job, I think, is to hopefully entertain and inform you for the next 50 minutes, and I understand that you're at the end of your very long day. In order to help me in this job, I've invited Dr. Roxana Karami, who is the senior optometrist in my practice, and she will be helping to discuss issues around patient preparation for cataract surgery and also post-operative management. So let's get started. Here's the outline. We're essentially going to discuss where cataract surgery has been, medical versus refractive cataract surgery, preparing the patient for cataract surgery, surgical techniques and tools which are interesting and new, intraocular lenses, eye drops, and post-operative management, and finally discuss where the field is heading. A brief history of cataract surgery advancements since 600 BC. So, in 600 BC, when a patient had a cataract, there was no way to remove that cataract from the eye. And so the practice commonly was couching, which involves essentially hitting the eye with a blunt instrument until the zonules broke and the lens fell into the vitreous cavity. And in this practice, there's no significant hope of restoring very usable vision, simply just to restore light entering into the eye. So fairly barbaric, but it does work. So usually patients would have somewhere between 2200 and count fingers vision when this was all over. It wasn't for another 2,000 years that the next major advance happened. A French physician developed a technique where a 10 millimeter incision, that's really big, a 10 millimeter incision would be made in the cornea, and the lens would be removed with a curette, and then the eye basically left to heal on its own. And so you can imagine this patient would be very light sensitive, sitting in the dark and in a significant amount of pain. Fast forward 100 years later, this is when sutures and topical anesthesia were invented. Certainly these are great things for cataract surgery. And then fast forward to 1949, this is the first intraocular lens that was placed into the eye. So the interesting story here is that this was first discovered in around World War II when an airman who had a shrapnel of acrylic in the eye was found to have essentially no inflammatory reaction. And so based on that, it was believed that lenses could actually be placed in the eye without significant damage in the long run. And so the first lens, you may have heard, resulted in a myopic shift of 20 diopters. The patient ended up becoming a minus 20 myope, simply because the index of refraction of the crown glass or the acrylic that was used was not taken into account, and essentially the lens was made to mimic the shape of the normal human lens, resulting in too strong of a power. Nowadays our lenses are a lot thicker and we're much better at predicting postoperative refraction. In the 70s, Charles Kalman visited his dentist, so the story goes, and discovered that the little instrument that is used to clean the teeth that makes a very high-pitched noise can also be used to remove cataract. And so this concept was brought to intraocular surgery. However, it was not really popularized or useful until foldable lenses were developed. The reason for this is that even though you could remove a cataract through a 3 or 4 millimeter incision, placement of a lens at that point still required you to widen that incision until you could fit in a 6 or 7 millimeter lens. And so at this point, this is what I would consider the dawn of the modern cataract era. The combination of small incision phaco emulsification plus a foldable lens to be able to be inserted through that same incision has launched what we consider modern day cataract surgery. So let's talk a little bit more about medical versus refractive cataract surgery. So this is a medical cataract. As you can see in this patient's right eye, we have a dense white cataract. We don't see a lot of these in the United States. And in fact, in residency, I went to a hospital in India called the Aravind Eye Hospital, and this is an interesting photo. You can notice here that there are actually 1, 2, 3, 4 patients in the room. There are 2 surgical microscopes and 2 operative teams. And the idea here is to maximize efficiency and operative volume. A surgical team would operate on one patient while the other patient is being prepared. And then as soon as the surgeon was finished with one patient, he would swing the microscope over and start operating on the other patient. And so this results in very efficient surgical turnover. Essentially, they could do about 50 to 100 cases per surgeon per day in these operating rooms. And I'd also, by the way, these are the kind of cataracts that we're taking out. These are black cataracts. I've actually only taken out 2 of these cataracts in the United States. those two cataracts are now sitting in a little jar in my office. And I show these to medical students and residents when they rotate with me. The other thing I wanted to point out is how little medical waste is generated at this hospital. If you look at these red bins on the kind of right third of the image, you'll see that this is all the waste that they'll generate for the entire day of 100 surgeries. Now in the United States, we'll generate an entire red bin pretty much every single case because we throw away everything. But here in Erevin, they sterilize the gowns and the instruments, and they're very, very good at reusing things. In fact, I remember that one of the ways we know when a surgical blade needs to be replaced is when you're handed the instrument, you try to cut into the eye, and the cornea does not become incised by the instrument. Then you realize the instrument's too dull and probably cannot be autoclaved anymore and needs to be replaced. So this is definitely a different health setting, but they really have spectacular outcomes, even compared to the United States. So cataract surgery benefits. There have been many, many, many things written about cataract surgery and its benefits. One of the primary ones is a reduction in falls. You can imagine what that is, a 16% reduction in hip fracture. And some interesting work that's actually come out of UCLA through a large meta-analysis of Medicare databases is that a cataract surgery can cause a 27% reduction in all-cause mortality. So what does that mean? That means that for any cause of dying after cataract surgery, it goes down by 27% in patients who've had surgery versus patients who have not. And this is thought to be not only related to the health benefits of not falling and not getting into car accidents, but also because patients are able to, for example, socialize better with their friends or pursue the hobbies that they would like to pursue because they can actually see. But nowadays, we don't talk just about medical cataract surgery. We actually want to look at the entire spectrum. What we do now, we consider refractive cataract surgery. So what does that mean? Essentially, I tell patients that there are three distances that they primarily would like to see. One is near, one is intermediate, and one is distance. So intermediate activities include things like playing with grandkids. Near intermediate involves reading medication labels. Distance, of course, is driving. The computer is somewhat intermediate. Gardening is near intermediate. Reading is primarily a near task. And golfing is distance. And sending emojis to your friends is primarily a near task. Now, nowadays, people want to do this all without the use of glasses. And so we'll talk about that. And this is essentially what we consider refractive cataract surgery. In this section, I'm going to have Dr. Roxana Korami present some of our preoperative evaluation and discuss how an integrated OD-MD practice works. So we like to do a good job communicating with the patients because essentially patients who go through cataract surgery all need to know the same things before surgery and after surgery. So here's how we do it. Let's imagine that you're going to a concert. So you may get automated emails 38 days before telling you about the lineup, then maybe 7 days before telling you about the parking, and then afterwards they may ask you to sign up for next year. So we try to do the same thing with our patients. We run these drip-style email text campaigns to help patients get preoperative and postoperative information. So imagine that the surgery is the concert, so at day 0, this is the actual thing that we're doing to them. So the system that I've developed actually over the last 2 years sends out booking details and emails 30 days, 14 days, 7 days, 2 days, 1 day before surgery, and then 1, 7, and 28 days after surgery. So the email that the patient might get may look like this, and it comes with a custom video, usually less than a minute. They don't really want to hear me talk for that long, about some instruction that's important to that 2-week time point. And on the back end, we create these templates so that the patients will get the right information. So I need to find a new thumbnail for that video, and I'll minimize it. But essentially, the video will be me talking to them about their surgery and about kind of instructions that are important. So next topic is qualifying the premium lens patient. Now, there's 3 things that essentially go into this process for us, but I won't talk about personality because this could be a completely different lecture. My area of interest in research is using psychometric analysis to figure out who are the patients that you're going to find that are happy after cataract surgery, and who are the patients who, after surgery, no matter what you do, are not going to be happy. And so there's a medical student and I launching this area of research soon. But we can't talk about that right now. There's not enough time. We're going to talk about spherical aberration and angle alpha and kappa today. So very briefly with spherical aberration, essentially it's a concept that the peripheral rays and the central rays are focused at different spots. So here I've put the peripheral rays in purple, tried to cleverly name those so that they sound the same, peripheral purple. And then the middle rays, the central rays, are in cyan, central cyan. So here's a situation of neutral spherical aberration where the peripheral and central rays are focused at the same spot. Now let's move those peripheral rays up. You can see the central rays, the cyan, are still at the same spot, but now the peripheral rays are more forward. Now, this is a situation of positive spherical aberration. The peripheral rays are focused ahead of central rays. Positive. Now, let's see another situation. Let's move those peripheral rays back. Now the peripheral rays are focused behind the central rays. This is a situation of negative spherical aberration. And just to show you those three situations again, neutral, positive, and negative. Let's talk about the human eye. The cornea actually starts with positive spherical aberration, plus 0.27 to plus 0.3, and this is stable throughout life. The lens in the eye, the natural lens, is a little bit negative, so minus 0.20 when young and getting more positive with age. So the total is plus 0.07 when young and increasing to plus 0.3 when patients are of cataract age. And the important thing here is that a little bit of positive spherical aberration is actually good. It results in the best possible image quality as determined by a study of US Navy pilots about 2 decades ago. So post-refractive, this changes. So as you saw, the cornea is this number, and then the number is small, slightly positive when young. Sorry, this should say plus 0.07, and increases to 0.3 when patients are of cataract age. But post-LASIK, what happens is really interesting. You can see here that essentially when patients are myopic and get myopic LASIK, their light rays are focused too forward in the eye, and when patients have LASIK surgery, you can see the peripheral rays don't move. The purple rays are still focused at the same point, but the center of the cornea gets flatter, and so those rays are focused further back, and this is what allows the focus point of the eye to shift back with myopic LASIK. So post-myopic LASIK, patients have increased spherical aberration because now the peripheral rays are focused in front of the central rays. The other situation, post-hyperopic LASIK, is, as you can imagine, the opposite. So you can see again here the purple peripheral rays have not changed, but the central rays have shifted forward. This is a situation of an eye that needs hyperopic LASIK. It's just a little bit too short, so we need to focus that eye and the light coming to the eye a little closer. So we make the cornea steeper in the middle, so thus the cyan central rays are focused closer, and now the peripheral rays are focused behind the central rays. This is a situation where hyperopic LASIK has created decreased spherical aberration. Now this gets somewhat confusing. There's also a concept called Q, and Q has these values. Essentially, instead of plus 0.27 like spherical aberration, the cornea has minus 0.26. Post-myopic LASIK or myopic LASIK increases Q value, and hyperopic LASIK decreases Q value. So this gets really confusing, right? So the most important thing to remember here is that both Q values and spherical aberration are a measure of corneal shape. However, Q is unitless. So think of it like this. Imagine that Q and spherical aberration are like miles per hour and kilometers per hour. They're both a measure of speed, but they just have different kind of units, or in the case of Q, no units. But they're both a measure of corneal shape. Technically, Q is a measure of corneal shape, so you'll see it on scans of the pentacam, for example, but you need a way for aberrometer to determine spherical aberration. The important thing with cataract surgery is that when you have an eye that you know has negative spherical aberration or neutral or positive, then you pick a lens that works well with it. So for example, if you have neutral spherical aberration, you can really pick any lens depending on your desire. So if you want to increase depth of focus, you can put in a positive spherical aberration lens, which I'll talk about later in this talk. If you want to increase image quality, you can put in a negative spherical aberration lens. And this is essentially what most manufacturers on the market have chosen to prioritize. That's why most lenses on the market have negative spherical aberration. But if that person, for example, had hyperopic LASIK, they already have negative spherical aberration, so you may not want to decrease that further. So in those cases, you would put in a neutral lens or a positive spherical aberration lens. And finally, in cases where the patient already has positive spherical aberration, such as myopic LASIK, this may be a situation where you would put in just a normal negative spherical aberration lens. Finally, let's talk about optical, pupil center, and visual axis. The optical center is the center of the eye based on the limbus, which is actually not that important. Then the pupil center is the center of the pupil. This is usually measured in the undilated state because undilated is how most patients live the majority of their lives. And the visual axis is the point at which the patient is looking through. So angle alpha, and by the way, these pictures are from Cataract Coach. This is one of my mentors from residency. He made these videos that are really great online. Angle alpha is essentially the distance between visual axis and optical center. But as we said, it's not really that important. Optical center is like a measure of the center of the eye relative to the limbus. Not that important. The really important one is called angle kappa. This is the difference between the visual axis where the patient is looking through and the pupil center. So let's talk more about angle kappa. And this is the most important thing for multifocal lenses, aside from making sure the patient has no glaucoma, retinal issues, corneal issues. So let's put a lens here on the eye, and let's reduce it just to red rings. just to make it simple. So imagine that this yellow dot is the visual axis. So we could potentially align the lens on the yellow dot because that would seem to be the most logical place to place it. However, that makes the rings decentered in the pupil, which degrades visual performance. On the other hand, we could move the lens to be aligned with the pupil center, which maximizes performance from the visual perspective of the pupil, but you can get aberrations because the lens is no longer centered on the visual axis. This is the dynamic tension of angle kappa, and this is what's important to minimize. Theoretically, we can put the lens in the eye, we can nudge it to a certain spot at the end of the surgery, but it probably won't stay there. And so the most important thing is making sure that angle kappa is as small as possible. The distance between the visual axis where the patient's looking through and the middle of the pupil, we want that distance to be as small as possible, and that's known as angle kappa. Many ways to measure this. On the IOL Master, you can look at something called the CW cord, which is made by Chang and Waring, CW cord. And these are two cataract surgeons, and their metric converts the angle in degrees to physical measurement. And generally, we look for, in my practice, less than 0.5. And for the lens star, you can add together the numbers at the bottom of that first page, PCX and PCY. And without the sign put in, the absolute value should be less than 0.6. And finally, higher order aberrations, we look at this on the pentacam, and you can look at the HOA, RMS, and we like to see this below 0.5 microns. Hello, in this section I want to discuss some of the intraocular lenses that are available on the market. As you recall earlier, most patients nowadays want to have some element of refractive surgery, being able to see some things without glasses. And so if we divide the spectrum into near, intermediate, and distance, we can see that there are lenses that fill each of these niches. So monofocal lenses are very good. They provide the best image quality at any of these distances, and the only downside is that they have a limited range. So if a patient is targeted for distance vision, pretty much they're just going to see distance vision. And if they're targeted for near, they're pretty much just going to see near. It's very, very important for patients to understand what they're going to see. So we actually spend a lot of our time discussing and counseling patients on what they expect to see after cataract surgery. The second category I would consider monofocal plus. These are lenses that give a little bit more depth of focus than the monofocal, but also don't have some of the side effects of the lenses that give more depth of focus, and we'll discuss some of those side effects in a little bit. The next group of lenses is the extended depth of focus, or EDOF lenses. These include the Vivity and the new EMV1. And finally, to cover the entire range, distance, intermediate, near, these are lenses like the PanOptix or the Synergy lens. These are considered true multifocal lenses. Prior to the PanOptix, which is a trifocal lens, we had multifocal lenses that would give distance and near, but potentially not intermediate. So the PanOptix is the first, and I guess now one of two available in the United States, trifocal lenses that give continuous range of vision. Let's talk about those first, since these are kind of the most interesting on the market. The first is called the PanOptix, made by Alcon. This is the lens that I use the most in my practice. And by the way, I have no financial relationships with any of these companies. I'm a completely impartial observer. My only goal is to have my patients be happy after surgery. And so this lens I've been pretty happy with. I placed the first one at UCLA about 2 years ago. And the PanOptix lens is designed to give distance, intermediate, and near. And essentially how I counsel my patients is I tell them in the FDA studies, 82% of the people who got the PanOptix lens reported never having to wear glasses again. And that's pretty good. But that means that there's 18% of patients who still have to wear glasses. And so that 18% covers need for very, very close activities such as sewing or threading a needle, or on the other end of the spectrum, some patients with PanOptix still want to have a little bit of distance correction if the lens does not heal perfectly to distance for night driving. So all in all, this is a pretty good lens. I'm pretty happy with it in the right patient. I do maybe 5% of my patients or 10% of my patients with the multifocal lens because I'm pretty strict with what patients are candidates to get this lens. So meaning they can have no corneal issues, no glaucoma, no retinal issues, no family history of these issues. And essentially that makes for a pretty happy patient with the PanOptix. Now, sometimes I'll tell patients, okay, you have some peripheral drusen or you're a glaucoma suspect, but no family history of glaucoma. This lens may not perform up to how it could in a person with a perfect eye. And so these are the conversations we have about patients to assess their candidacy. And of course, we always warn them about glare and halos at nighttime. This is a property of the ring configuration on the surface of the lens. And this is something that I tell patients everyone will experience, but not everyone will be bothered by it. So they go into this understanding they're going to see glare and halos. The second lens in this category is made by Alcon's competitor, J&J, and it's called the Synergy. I have personally not used this lens, but I've heard good things about it. It's also trifocal lens, also gives continuous range of vision. J&J's claim to fame with this lens is this OptiBlue technology that's supposed to reduce glare and halos. I can't speak to it much just because I haven't used it, but I know that other people are finding some success with this lens also. The next category of lenses are extended depth of focus lenses, such as the Vivity or the EMV1. So these are lenses that, if placed at distance, can also cover intermediate. The original version of this, or the original lens that was on the market, still is called the Symphony lens, made by J&J. Then Alcon came out with the Vivity lens, which you can see doesn't have rings like the Panoptics, but has this kind of central hump. And this hump is not supposed to split the light. It's supposed to, what do they say? It's supposed to shift the light and stretch the light, which I think are interesting terms. My personal experience, and again, I have no financial bias either way with any of these lenses, with any company really. My personal bias is that this lens doesn't work quite as well as a Panoptics for what I want it to do with patients. So for example, if a patient's looking for extended depth of focus, they also want a little bit of near vision, and this lens doesn't provide near, it provides distance and intermediate. The other thing that I found is tricky in my patients, I've implanted about 70 or 80 of these, is that it's still affected by corneal issues, and it also takes some time for some patients. Maybe 10% of patients have an extended neuroadaptation period, meaning that it's going to take them many, many, many months before they their brain figures out how to use the lens, so to speak. So I have not been putting in as many of these as I thought I would. I primarily place Panoptics lenses now, as long as patients are a candidate. My criteria are pretty strict for both Panoptics and Vivity, so if the patient qualifies, my reasoning is I'd rather just give them a little bit more depth of focus and have them understand that they're going to have more glare and halos. The Rayner EMV1 is also an extended depth of focus lens, but has an interesting design. It uses positive spherical aberration. So my discussion earlier about spherical aberration is essentially to set you up for this portion of the talk. So the Rayner EMV1 essentially trades image quality, because positive spherical aberration decreases image quality, for depth of focus, which is what positive spherical aberration allows for. And so I've placed a few of these lenses. I haven't formed a strong opinion on them quite yet, but they seem promising as an extended depth of focus technology. So now let's talk about monofocal plus. These are lenses like on the left-hand side of the screen, you see the iHance, which is a J&J lens. Very, very similar concept to the Rayner EMV1 that I just discussed, where a little bit of positive spherical aberration is used at the center to enhance the depth of focus. So this is useful for people who have retinal disease, glaucoma, or corneal issues who want a little bit more depth of focus. But very, very important to not oversell this lens, because if the patient thinks that they're going to get true intermediate or true near, then they're going to be very disappointed, because this is primarily like a multifocal lens and maybe one line more of intermediate than a monofocal lens. And on the right-hand side, this is a picture of the BVI iPure, which also claims to give a little bit more depth of focus, but not on the order of a EDOF lens or a multifocal lens. And finally, monofocal lens. There are some interesting monofocal lenses on the market as well. One is called the RX Sight, and I've put version 2 here because this recently was released in the United States. So the RX Sight lens is a very, very interesting lens that essentially allows for modification of the lens in vivo, in the eye, after placement. So a patient can have this lens placed and then over the next couple months, over the next few visits, use calibrated UV laser device in order to change the shape of the lens. So this is very, very useful for those eyes which are very, very hard to nail in terms of a refractive target, post-LASIK patients, especially post-RK, or if the eye is just really strange or very long or very short, this is a good lens in those situations. The reason why I put version 2 here is that version 1, because UV light is used in order to modulate the shape of the lens, version 1 certainly had some issues. Patients would have to use sunglasses, essentially outdoors, or anytime they might be encountering UV light. And that's hard to do. And so oftentimes, I shouldn't say oftentimes, but sometimes patients would actually go out to the beach, forget their sunglasses, and end up with a lens that was mouse-shapen inside the eye. And there's only so many times that you can do this UV correction before the treatment is essentially locked in. Version 2 is a little bit better because it contains this UV shield. And the idea with the UV shield is that it allows the user of the lens, the patient, to not have to be so photophobic and scared of any source of UV light, because some of that UV light is filtered. But we still wouldn't recommend sending out a patient into the world without sunglasses after an RX sight lens. So this is a lens that can be very useful in certain situations, but also has some cautionary warnings associated. And a really cool lens I haven't used yet, but I've heard good things about, is the AccuFocus small aperture lens. So imagine this is like a pinhole lens. You can't really wear pinhole glasses and see the world very well, but you can use a small aperture lens like this if the patient dilates or just has a larger pupil. This small aperture lens can essentially simulate a pinhole effect in the eye. So useful for people with corneal scars or any other pathology that might cause irregularity in the cornea, because this pinhole can effectively negate some of that. So it'd be interesting to use this lens as well. I want to share briefly some of the techniques that I think have been interesting in cataract surgery in the last couple of years. The first is this device called the MyLoop. And what the device does is allow us to cut apart cataracts with a physical device instead of using phacoemulsification only. The benefit of phacoemulsification is that pretty much everyone learns how to do it during residency, but the issue is that phacoemulsification, ultrasonic energy, can harm the endothelium and other structures inside the eye if deployed to too great of an extent, for example, for a very dense cataract. So in this technique, the MyLoop is this metal snare that is used to cut the lens into halves and even smaller pieces. And this technique can be used in order to make sure that a dense lens does not require too much phacoemulsification energy and helps corneal recovery. The second technique I want to discuss is this little device called the Zepto. This is a device that makes the initial capsulorhexis for cataract surgery. And the idea here is that normally the surgeon needs to tear a fairly circular opening in the capsule. This is important for lens centration and preventing tilt of the cataract, of the new lens, I should say, the intraocular lens. What the Zepto does is allow us to insert a device that will make a perfectly circular opening every single time. This is a disposable device. It's inserted into the eye. It's deployed inside the eye, and it makes a perfect opening in the capsule so that we can proceed further. So, a lot of surgeons say this is not a necessary thing because a perfectly circular opening does not necessarily mean lens centration is going to be optimal, and it's not even necessarily that useful. But this is something nice that some patients, get, and it looks nice afterwards because the opening is perfectly circular. Femtosecond laser. You've probably heard about. This is a technology that's been around for potentially about 10 years. And the idea here is that after docking the patient's eye to the laser, the surgeon can set parameters such as the cut of the lens, the initial incisions, any arcuates that need to be made. And doing this is helpful. I primarily use it in two circumstances in my practice. I do femtosecond laser on potentially 5 to 10% of my patients, only those who I feel like would benefit from it. And those people are people with very dense lenses. Usually if we grade them 3+ or 4+ nuclear sclerotic cataract, we'll do femtosecond laser. Or alternatively, if they have Fuchs dystrophy or some kind of endothelial dystrophy where we have to be very, very gentle on the endothelium, we may use something like the femtosecond laser. This approach is based on some research that I've done when I was on the Cataract Preferred Practice Patterns Committee with the Academy of Ophthalmology. Here, I looked at all the evidence for femtosecond laser, and it's fairly mixed. There are some people who swear by it, other people say that it doesn't make a huge difference. And so that's why, in my practice, my approach is to only use it in situations where the cataract is very, very dense, or if the patient has Fuchs dystrophy. And so here, the laser is being programmed. You can see that the cut depth of the laser is set. And at this point, the pedal is pressed and a perfect capsulorhexis is made of a precise diameter. In the next step, what you're going to see is that a grid, kind of a waffle pattern, is made in the lens. And this waffle pattern allows the lens to essentially be pre-emulsified so that it's easy to remove. It essentially can soften a very, very dense lens. And finally, what you're going to notice after the cut is that the primary, first we're doing the arcuates. These are limbo-relaxing incisions there in the top, and then in the bottom, you're seeing a primary incision and a secondary incision. So that is femtosecond laser. And I would say another interesting innovation has been MIGS surgery. You can see here this is on a gonio prism in the R. A eye stent is being placed. And the eye stent I'm sure you guys have seen already, is a injectable stent that goes into the trabecular meshwork that can reduce pressure. These are stents that we give to people, we place in people who have a diagnosis of primary open-angle glaucoma. I think the second one's being placed now. Okay, good. So in the second portion, you can see the trabecular meshwork is visualized. This is all very, very small under the microscope, and placement requires steady touch. And to cannulate the opening well usually means that there's a little bit of blood reflux, and so sometimes after you've done it well, you lose your view, and just have to hope that the stent got into the right position. And patients after eye stent can sometimes have heme in the first day after surgery along with elevated pressure, but usually most patients are pretty clear by post-op day 1. And finally, this is a cool technique. This is called the Yamani technique, developed by Dr. Yamani. And what it is used for is to fixate the lens in an eye where there's no capsular support. Let's say that there is a posterior capsular tear, and there's no anterior capsular support, meaning that maybe the anterior capsule was torn as well. So in the first part of the video, you'll see this low temperature cautery being used to melt one of the ends of this lens that's being placed into the eye into a bulb. And so after this is done on one side, the other haptic, so now you can finally see the lens optic, is externalized through this needle cannula, and then the other side is going to be melted into a little bulb as well. And the benefit of doing this technique is that this is sutureless fixation of a lens. Sutures can certainly break, sutures can erode, sutures can cause all sorts of issues, and so if this technique is employed, it can restore vision in a patient and without relying on sutures. And generally these bulbs are not known to extrude through the sclera, and they can hold the lens in position for the long run. So a couple cool things that have happened in post-operative management. This first one is a insertable pellet called Dextenza, and this is at the end of cataract surgery. The inferior or superior puncta can be dilated. You can see here there are two perspectives in this video, the microscope view and then the I don't know, somebody recording the surgery view. And after a pretty vigorously dilating the puncta, this was my experience as well, pretty aggressive dilation of the puncta, this little pellet of dexamethasone can be inserted, and this pellet will slowly release the medication over time so that the patient doesn't have to use post-operative steroid drop. So it sounds like a good concept. Also, the other good thing that it does for some patients is that because it blocks the puncta, it essentially serves as a punctal plug. And as a punctal plug, it can help patients be less dry after cataract surgery. So I found good experience with this in the kind of patient who doesn't want to use postoperative drops, or you don't think they're going to use their postoperative drops. This is a good thing to place. I had 2 patients who had tearing after this, and this thing can be flushed out. And so overall, it's a pretty good treatment. The next one is a kind of a evolution of this treatment called the DexiQ. The DexiQ is this insertable, I don't know what to call this, just kind of like slow release bolus of steroid drop, also dexamethasone, but the medication is released slowly over time. This is placed into the anterior chamber or kind of near the zonules underneath the iris after cataract surgery, and the medication is released essentially at the site that's needed, and there are less drops necessary for the patients to use. And finally, one of the interesting things that have happened in drops is drop compounding. So patients have a lot of drops on different schedules, so some of these pharmacies will actually compound these drops together. You can see, the Pred, Moxi, Brom is all those 3 medications together, so there are less drops for the patient to actually apply. And usually these drops are a little bit cheaper, these compound drops. You can get a bottle of the Pred, Moxi, Brom for potentially only $40. I think I had heard from them last I checked in with this company. So this is a kind of a small improvement in postoperative drops. Finally, where are we going with cataract surgery? So I talk about 3 things. One is the GRAIL study. So the Holy Grail, I guess that's why it's called the GRAIL study, in cataract surgery is to be able to implant a lens that is accommodating. And so this company on the market, Juvene LensGen, they have created this lens which has been so far implanted outside of the United States for testing purposes, and have actually reported 1-year data a few months ago that was pretty good. Essentially, you, instead of placing just a planar lens, like all the lenses on the market, a blue kind of space-filling scaffolding is injected into the eye, and then the lens is able to change shape inside the eye, just like the natural lens, to be more flat or to be more vaulted. And so in 1 year data in 45 eyes, 14 of the patients binocular implantations. For the monocular implantation, 100% patients were 20/25 plus at distance, and 95% 20/25, and 50% 20/30, with the majority they report 20/40 or better. Now, if you compare this to a lens like the Panoptics generally, you're going to see pretty close to 20/20 vision for all distances, distance, intermediate, and near. But the difference here is that this lens theoretically could be used in anyone. You don't have to worry about retinal pathology or corneal pathology as much, because this lens focuses theoretically more the available light to the retina. So it's not really splitting the light like the multifocal lenses. This is why it's such a big innovation. And of the patients who were implanted binocularly, they didn't really report exactly the numbers, but they said the mean distance and intermediate vision was 20/20, and the near was 20/30, 2 or better. So they're still a little bit tight-lipped about the details of this lens, but this is actually one of 4 lenses that is being developed that can accommodate. Some use fluid that move from outer pockets peripherally to the more central lens body in order to create increased depth of focus or increased near. But this is definitely a direction that I see the field going, and hopefully in the next 5 years, maybe 10 years, we'll have a lens that works really well, that's accommodating. And then most patients, we can probably recommend the same lens instead of trying to choose between multifocal and EDOF and monofocal and doing mini monovision. This hopefully can make choices easier and give people better lens options. There are more trifocals coming out. This is the AT Lisa, which is another trifocal lens coming out to the market. I imagine this will be fairly similar to the Panoptics with certain pluses and minuses depending on what kind of patient you place it into. And finally, this last technology is pretty cool. This is called the Perfect Lens. This is a way to use a femtosecond laser, as you can see in kind of panel A, to be able to reshape a lens after it's been implanted in the eye. So that's panel B. So theoretically, this company says you can take a monofocal lens that's already been implanted. Let's say a patient had surgery in 2005 and they have a PC-BOO in the eye. You could take that lens, you can etch a multifocal pattern on it to give the patient's multifocality. Or if a patient healed to a -2 and you want them to be at a -3, you could do that with this. And theoretically, what's really cool is they said that you could potentially even erase the pattern so patients could try out different lenses when the lens is already implanted in the eye. So this is a really cool technology. I haven't heard anything recently from this company about this. I know that they've proved the model in vivo in animals. I don't know if they're moving to human trials quite yet, but this is very exciting. So this is essentially the end of my talk. Hopefully it was entertaining and informative. And if you have any questions, Dr. Karami's email address is here, and my email address is here as well. And my mission in my practice is to be essentially the best cataract and LASIK practice it's covered here, I should say, in the world. This is a picture of our small but growing team. We have Dr. Karami here, Dr. Chang here next to her, my surgery scheduler, one of my technicians, and then Janelle, who's one of our scribes. And so over the last 2 years that I've been at UCLA, we've really done a good job, I think. We have a ton of patients who've written good things about us online, and we are actually hiring right now. So I'll put in a shameless plug. This is an academic position. If you're interested, please let us know. You have 7 OD colleagues in the division, so in the same hallway. It's an integrated practice for 4 physicians. No OD we've hired has ever left, so hopefully that says good things about the ODs who work here. There's a pension, no call, no nights, no weekends, and learning, growth, and happy patients. So it was very, very good to speak with you, and I thank you for inviting me, and hopefully you learned something and it was entertaining, and hope to hear from you soon. Have a good one.